My name is Amy Skillman, for those of you who don't know me, and I'm director of the MA in Cultural Sustainability here at Goucher College. I want to welcome you to tonight's conversation about culturally relevant healthcare delivery. But before we begin, I have the usual kind of quick reminders. If you are interested in closed captioning, it is available by clicking on the CC button at the bottom of your screen. We are recording this, so if you prefer not to be on screen, simply turn off your video. And while we're doing introductions, please keep your microphone on mute. If not, Taylor might mute you. And you can put your setting on speaker view so that you maximize seeing all the speakers. And then when we open it up for questions and comments, feel free to turn your video on so that we feel like we're all in a room together. These events are designed as conversations with some opening remarks by our speakers and then a moderated dialogue. So we encourage you to communicate with each other using the chat function. That's why we call this Chat Fest. But hold your questions until we open it up for dialogue a little bit later in the hour. And feel free to go ahead and begin chatting by entering something about who you are and why you're here in the chat, if you feel like it, by way of introduction. So again, I'm so pleased to welcome you to the third of our 4 sessions in our Fall Chat Fest series of online conversations with sustainability and cultural activists. Our sessions have been scheduled every other Tuesday throughout September and October. And if you missed any of our previous conversations, you can find recordings of them on our YouTube page, which is called Cultural Sustainability at Goucher College. But Taylor is going to put the link to the YouTube page in the chat so that you can save that. And there you can look at the past ones and any future ones, but you'll have the link. Our next conversation will be on October 24th, which is not every other Tuesday this particular time, but we will be offering an information session about the MAX program in particular, the MAX being the MA in Cultural Sustainability here at Goucher College. So if you want to learn more about the courses that we offer or the faculty who work with our students and the kinds of careers that our students achieve, the internships they're involved in, feel free to join us then. And again, Taylor Seitzinger, who is our graduate admissions counselor, will post 2 more links in the chat. One is the link to the MA, to the webpage for the Cultural Sustainability Master's Program. And then the other is the registration page for the fall series, where you can go ahead and sign up for that workshop if you're interested in coming back for that. So tonight's theme, culturally relevant healthcare delivery, is something that is of interest to many students and alumni in our program. In fact, 2 of our alumnae are featured in tonight's conversation. They were in the program at different times, but they have connected as alumni because of their shared interest in health equity. Our moderator, Cecelia Ottenweller, completed the program in 2020. Her capstone was an ethnography project examining the cultural issues behind Black maternal health disparities in Houston, Texas. Today, she is an independent researcher, writer, and content strategist based in Houston, where her most recent project, completely opposite end of the spectrum, right, involved documenting and writing the centennial history of the Houston Zoo. So you want to be sure to check out her recent article, Marrying an Elephant, Adopting a Chimp, Tales from the Life of Houston's Wildest Zookeeper. I love that. I think you can find it online in the Texas Monthly magazine. Cecilia's other projects include museum exhibit content development and interpretive design for zoo habitats. She also has worked in digital media, creating and managing all kinds of special projects in video, audio, animation, education programs and marketing campaigns. Dr. Andrea Caracostsis is the Chief Executive Officer of the Asian American Health Coalition, doing business as Hope Clinic, which was designated a federally qualified health center in 2012. As a physician with a master's in public health, Dr. Caracostsis has over 10 years experience working with migrant and community health centers with vulnerable populations. She worked as a provider at the Migrant Health Center and served as a consultant to the Migrant Clinicians Health Center, Migrant Clinicians Network, providing technical assistance to community health centers around the country. Dr. Caracostsis has been active in the Bureau of Primary Healthcare's Health Disparities Collaborative and is a member of many national healthcare advisory committees. Under her leadership since 2008, the Hope Clinic has advanced significantly in its efforts to reduce health disparities through a variety of processes that I hope she'll share with us tonight. And finally, our third participant tonight, Velesha Louise, received her MA in Cultural Sustainability from Goucher in 2022. She is a second-generation perinatal specialist, doula, and birth activist who is passionate about service to expectant and new parents. Her combined expertise in women's wellness and birth work is over 8 years in practice. Velesha believes every woman should have emotional, physical, and mental support while she is in all stages of the birthing process, including pregnancy, birth, postpartum, and parenting and newborn care. She is an advocate and educator for a woman to know her rights and choices for her care. She has worked with women from the tri-state area around Baltimore, as well as overseas women of color and deployed military families from the USA, Canada, United Kingdom, and Italy. She has credentials as a holistic lifestyle educator, as well as a Master of Arts, well, I mentioned that already, in cultural sustainability at Goucher College. So please join me in welcoming, you can welcome me too, but welcoming Cecelia, Velesha, and Andrea, and I will turn things over to Cecelia.
Thank you very much, Amy. And also welcome to both Velesha and Andrea. I'm very grateful that you all agreed to join us for this discussion this evening. So I don't want to waste any time on fluff. I'd like to jump in and just go ahead and let you all talk about who you are, what you do, and why you're here. And Andrea, do you want to lead us off?
Sure, thank you so much. And if you don't mind, I'm going to share a few PowerPoint slides so that you can kind of get a graphic depiction of why I'm here. So I hope you can see my slides right now. Let me see, here we go. Okay, so really, I've been leading Hope Clinic. First of all, I'm originally from La Paz, Bolivia in South America. I came to the United States in 1996. So it's been a long time since I've been here. I completed my studies here and somehow stumbled into the world of federally qualified health centers and really fell in love with the model of what this type of institution does, which is kind of share the burden of care between the government, the community, and the philanthropic world. And I think that mix was really amazing because it puts the whole community in charge. Something about Hope Clinic. Hope Clinic is one of the most diverse federally qualified health centers or community health centers in the country. And we actually have 5 clinics. We serve patients in 60 different languages, and we birth patients from over 90 different countries. So we birth about 2,000 babies a year. Some of the services that we offer are listed here, but really, like my staff says, from cradle to grave. And we really try to integrate care because the American healthcare system is not easy to navigate, and especially women's healthcare is divided by sections of your body. Half of your body goes right and the other half goes left, which also means that you need transportation, time off work, and finding a provider that you actually integrate with and like. So our mission is really to provide that integrated care for the whole family in one place. So we provide pediatrics, women's care, behavioral health, nutrition, eye care, dental, and all kinds of wraparound services around the needs of the patient. And something very unique about us that no other health center does in Houston is that we deliver our own patients. So our team of doctors actually goes into the hospital and meets the women in the place where they are most vulnerable. This is a depiction of our diversity. So I really like this slide because even if you can't read all the names of the languages and countries that we serve, you can really see that we have an incredible reach across the whole universe of diversity here in Houston. So and our diversity really is a reflection of globality of healthcare needs in this country, including, every single war, conflict there is in the world is reflected back into Houston. Houston is one of the largest entry points for refugee patients. So we've seen patients from the Gulf War, Iraqis, Kurdish, then we see all the Rohingyas and the Burmese, and of course, then we saw the Afghans, and now we're seeing some of the Russians in addition to additional Afghans coming through our doors. This is Houston. Houston is a very large city, the fourth largest city in the country. And you can see in red the locations where our clinics are located. We're in the southwest corner and then kind of the north part of the city. Southwest corner, incredibly Asian American heavy, a lot of Vietnamese, Chinese, Indian Americans, and other Asian communities are buried, as well as Middle Eastern Arabic communities. And in the north side, many more of the Hispanic population, including a lot of the children that have been unaccompanied minors that came in through their borders in the last few years. So here is where we are located, certainly fourth largest city, most diverse city with over 145 languages spoken in Houston. This is just, number of patients and their footprint. We take care of about 28,000 lives. We have a budget over $30 million, and right now we have over 250 staff. So still growing. And the picture in my background is the lobby of our newest clinic. And definitely the clinic is very involved in upstream healthcare. We understand that meeting the patient not necessarily inside the clinic, but outside their clinic walls, and working a lot, understanding their environment and building it back into our clinic. And so that is my presentation for introduction card. Thank you, Cecelia.
You're very welcome. Thank you very much. That was a lot of material to get into a small space of time. You did beautifully. Velesha, would you like to introduce yourself to us and tell us more about your work?
Sure. I'm Velesha Louise, and I work as a doula. And a doula happens to be someone who is not just a birth advocate, but also a companion for emotional, physiological, and emotional support for mothers who are either pregnant, going into postpartum, or looking for care along the way. Like in my intro, it's important for y'all to know that I lean really heavy into being a birth advocate because I believe women should have the autonomy to make the decisions for what happens to their body when they're pregnant. And it comes from a place of informed consent. And when I work with a lot of the clients in the DC, Virginia, Maryland area, Northern Virginia, many times it's easy to be able to stick to only one route of having a child, whether it be in the hospital setting and just having an OBGYN. So with the clients I work with actively every day within private care, as well as working with different agencies, they're able to know their choices, because I believe when women know their choices and their options, they can be able to a la carte, like a buffet, the type of birth they want to have, the provider they want to have to support them. Also, they're able to build their birth team to know the specialists that can cater to them depending on their medical history or the holistic care they want to have. leading into the hospital or the facility, or choosing to have a birth at home, who should be there, whether it's midwives with a doula, a midwives assistant, and also knowing at the end of the day that the birth plan that they went into in the facility is respected and it's supported by myself as well as the team that serves them. So that's a little bit more about what I do on a day-to-day basis. And I think it's also important to also bring to the table that all doulas are not the same. What makes me different is I really focus on advocacy. And advocacy is really teaching families how to know what their rights are, and knowing not how to be amazing patients, but knowing how to advocate for themselves and then advocate for their family, and also the importance of modeled care, and knowing that cultural competency is important to be brought in when any family is getting care, whether they have different moral beliefs, traditions, customs, or values. I believe those are things that are brought into a mother's care and how she not just carries a baby, but also her environment and the people around her. So in the work I do, it's important that the women are able to have a voice, have a support system, be supported, and also be able to bring in holistic practices that I am able to integrate along the way, so that they're not able to just see carrying a baby is just physiological. It also is very much emotional. And once they're able to see the holistic picture and carrying a baby and have the support of someone like me as a doula, who is a birth coach, who is an educator, who is an advocate, I believe it allows their births and their experiences to be much better. And they have a better story at the end of the day. And more importantly, they're able to really pivot and navigate the system when they're there with a doula, whether it's myself or a doula who's a colleague. So that's just a little bit about what I do on a day-to-day basis. And it's also important to know that as a doula, my job also is to give preventative care options to mothers when they're in postpartum, which also is a passion of mine. I don't just work in births, but I also work in postpartum to let them know how to take care of themselves. They're taking care of themselves first, filling up their cup from a standpoint of resting, eating properly, making sure that the type of birth they had is not brushed aside or dismissed. They have people to come in their home to take care of them, look after them. And really being a doula is really being a mother's servant first. So I look after the family. However, the core importance for me as a doula is to focus on the mother, because my mantra is, when a mother's okay, the whole house is okay, and the family unit can operate much better. But when she's in a place of disarray and she doesn't have the support in any area of her life, it's very difficult for her to be able to function in her optimal health. And it's difficult for her to be able to really get the voice and to have the support system that she needs. So my job, and when I work with my family specifically, is to really be able to pull the voice out of them, or to be able to encourage them when they need to be heard, and really validate them so they're not dismissed, and that they're able to really be able to channel and champion the birth that they want, their health care that they want. And I believe it can resonate in all areas of their family moving forward. And when a mom is able to change her thoughts about a birth, whether it's from an advocacy standpoint or from a functional standpoint, I believe it changes the trajectory of her lifestyle and her family and her legacy.
Thank you very much. This is something you didn't even look at notes. I think you may have that written in your heart.
Yeah, I do.
Yeah. And you're also, I'd like to point out too, and Amy had already said this, that you're a graduate from the Max program at Goucher.
Yes, I am.
Okay, great. We're going to get to in a moment. Just I'd like to, I think at some point this evening we'll talk a little bit about how that experience with your degree program has actually augmented or affected your practice. But the first thing I want to ask you all, Andrea, when you and I were talking last week, one of the things that you said that I thought was so profoundly important was what actually is culture, right? And that came out of you because you were talking about how cultural competence, there's perceptions of it, and then what it is actually when the rubber hits the road. And I'd love for you to talk about that more. Tell me about what you've learned about defining what culture is and how important that is in the practice.
Yes, definitely. Leading Hope Clinic and walking through our waiting room is really like walking through the United Nations. It's a melee of different cultures, different religions, different sounds and food choices, and it's really fantastic. And you wonder, how is it that so people from such diverse backgrounds can sit all in one waiting room and get along? And I think that one of the incredible things that I have learned is that culture is dialogue. I think that we all have a lot to offer from each other, and that speaking the language or belonging to that racial group does not make you cultural competent with that per se. That what really gives you that cultural competency is really being able to understand, accept, and respect other person's points of views and choices of life. And that really transpires in our services. We have hired most of our staff from our waiting room, help people really educate them into professions that can further their economic output, and also as well as their engagement with their own people. And I think that has really brought into our clinic a different level of competency beyond the pure language interpretation. And that is evident when when just like Velesha was talking about, what are the beliefs of women surrounding birth, for example. They're very different in different cultures, how they value the birth, the birth process, how they feel about maternity, and what do they do after the birth of the child. Some groups will not take the baby out, for 30 days. Some other people want to baptize them at 3 months. And so there's a variety of ways in which women celebrate the life of the baby and that maternity part. And Western medicine only has one way, and that is the highway. And I think that bringing that sensitivity from the provider pulpit, from the MA's point of view, where we're constantly educating each other about what we believe, and embracing that diversity really starts in the heart. It starts in your love for globality. And I think it's very important for all of us to understand that we don't live in an isolated world where we do things per prescription. We actually live in a globalized environment where we are impacted by every single activity that happens around the globe, and eventually we feel it back here. So being open and accepting is what cultural competence is to me.
I love it. Velesha, do you want to add anything to it? Do you have anything that you'd like to say about that?
Yes, I was also going to add to that. It also is about seeing your reflection in the person that's working with you. And it's not just about language, but it's knowing that, if you see someone who looks like you, you know that you can really lay down all your worries and your frustration, and someone can empathize with you. And even if they don't have the same struggle that you've had, whether it be from a health perspective, it's just natural for human nature to attach themselves to people who look like them in their reflection, or someone who has the same language or eats the same food. So I agree 100% with what Dr. Andrea said. Those things are very vital, I believe, in healthcare, because it allows families to be able to then get the best care. And it allows the people who are working with them to be able to see diversity, not just in the care they give, but also in making sure they're understanding and having a much more expansive global mind. And one way is not the only way to care for a family. And there's multiple ways, and that's how you also preserve a family in a way, in a culture of life for that community as well.
Thank you. Well, one of the things that kind of comes to my mind when I'm listening to both of you talk about this is that when we're talking especially about women's health, that we're not just talking about cultural politics, we're also talking about gender politics within their cultures. So it's possible that you could be working with, Andrea, you work with people from a huge variety of cultures, especially with the refugees that are coming in. And some of those communities, or those cultural communities, don't have the same kind of balanced perspective, I guess, that maybe we try to idealize that we have in the West towards gender and gender roles and who gets to call the shots in the family and that kind of stuff. Tell me a little bit about, both of you, tell me about what it's been like to navigate that kind of politics in the cultural differences. Velesha, let's start with you.
Sure. So for me, and navigating it for me, it's more coming in into creating a safe space. And a safe space means that I'm not just coming in and asking what they need. I might take more time to really delve into understanding their food, or, if there's different days or Sabbath that they happen to observe. And I think for me as a woman of color, it's important that I come in and give people the space that I work with who don't look like me or have the same beliefs or just the same system of caring for the women, to understand an example of coming in their home and knowing that they don't wear shoes in the house. That could be a very easy way to create a safe space. Or understanding there's certain foods that a mother might have to eat while she's going through her pregnancy, and me acknowledging that and not coming from a place of curiosity, but just coming from a place of observation, and then them really leading me in the conversation to say, this is why we do this. This is what it helps out with the mothers. And then from there, they're kind of like the project manager and can really guide me to have a much more understanding, and then bring in the questions in, because they see me as not someone who's just coming and trying to take, but I'm coming in like with open hands to have a better understanding. That's usually for me as a doula, and a lot of the doulas I work with when we work in a cultural competency like scope, when we're working with many women who either look like us or who do not. And I think that's the easiest way to be able to have space where it's safe, where there's trust, and then it then allows so much more conversation to then be there. And it's easier to then be able to have the exchange of what can and can't be done, what is the norm, or what is then given as advice to then say, this is what you can or cannot do if you were going to go into a certain facility for healthcare.
Okay. Andrea, what about you? How is it? You have a huge population, so how is it that you've dealt with issues when you end up with the gender politics of a particular culture that cause problems in your exam rooms and your practice?
Well, certainly, we've had our share of really trying to learn about how people perceive gender roles, and I think it's you learn to really, first of all, value, provide the space for to understand what is it of value to that you bring at the table, right? A little bit very much like Velesha said, that you need to understand what do they value, what are their priorities, not yours. And in terms of really moving the needle in equality and gender equality for the different communities, um, especially new communities, they're already coming with a lot of fear. And they are already, they've been generation after generation, they lived in an environment where the gender roles were really defined by their religion, by their government, and their clinic at this point, other than surrounding the community with with what they really perceive as their priorities, is much more important to us than trying to change their beliefs about gender role. I think that as they generations move across and as they figure their way out around, definitely they will learn some of the things that are more harder to navigate are certain the intersection between the legality of some of their activities and the traditional values that they hold. For example, leaving very young children alone at home and having the neighbor call the police and then CPS getting involved. So some of those, so we do a lot of education for our new parents and new immigrants about, what are some of the things that, how things are done in the United States and the things that they need to watch out for. But we don't necessarily tell them what they have to think or not think. I think that this is a discovery process. It's a road process. And the other thing I'll say is that respect, when you listen to others, others tend to listen to you. So our role really mainly is to listen to what the patient and the individual has to say. Don't forget that people are coming to us from the clinic role, right? So they have a medical need, whether they're sick or they're seeking, preventive care. But going into a doctor's office is absolutely not the same as meeting someone in their home. People already come in with a fear factor and a distress factor many times into our clinic. So our role is to help people relax, listen to their needs, and hopefully meet some of those needs they have. And I think that's what I call value, right? Everybody talks about value health, value care. And who is the value for? Is it the value for your pocketbook, or is it really a value for where the patient stands? And I think that definitely the value is for where the patient stands.
Okay. Very good. Yeah, I know that's a really complicated question. And one of the things that's really different about both of you, you know, that's between both of you, that's a difference, is that Velesha, in some ways, this is my perception, and I want you to correct me if I'm wrong, but you have patients that are self-selecting because they choose to believe that they choose a doula to be there in their birth process, right? So they take that extra step. And whereas with you, Andrea, you have a community that, because of you're an FQHC, that's a particular group of people who are limited as far as access to healthcare in the environment, right? Or am I wrong about that?
To a certain degree, right? We actually do have a doula in our program, and we're recruiting more doulas. So we're a big doula fan here. And some of our efforts were curtailed during COVID, of course, when we, could not have that much face-to-face contact. But definitely, I mean, we're big believers in that pregnancy is one of those windows where women are really open and receptive to getting care and learning and changing behavior. So we surround our pregnant ladies by a lot of healthcare education. And during COVID, we partnered with an app called Baby Scripts and help develop a lot of our educational material through this app. And the app is interactive with the mom. And I know that technology is not for everybody, but for the young moms, especially immigrant moms, that's the way they communicate with their home countries, right? Through WeChat, WhatsApp, and all these chat groups that they belong to. And we took advantage of that and really allowed the development of educational materials on demand through this app. And you can actually track and see what women are interested in learning, right? So women may be interested in learning about their doctor. And so you feed them more information about their doctor, or maybe interested in learning about food, where to get free meals or WIC, and how to get vouchers. And so you can feed them more of that. In addition, for women at risk, we provide them with a blood pressure cuff there, and we can see if they're using it, and if their blood pressure is if they're holding steady, and then interact with them and say, yeah, I haven't seen you take your blood pressure in the last 2 days, all okay. So there's a lot on the technology that we have used to embrace our women and bridge that gap where someone has to go to their house, or or they have to come to the clinic, because every trip to any site is a demand on time, transportation, expense, childcare. It is not easy. So definitely technology in that app has served us really well in the last 3 years. And we at any time we have about 1,000 women enrolled in the app, so it's pretty active.
That's tremendous. Velesha, do you have anything to say?
I would say I would add to that. Not all women are through self-service. Some are through collectives, some are through organizations that they're part of. And that's a lot of the reason, because some women don't know what a doula is. And it doesn't mean they don't know, but sometimes in other countries that they come from, the word doula is not a common phrase. Like, they do not call them doulas in other countries. They might call them like the maternal healer or a midwife. For instance, when I was working in Germany with the military, they saw me as a midwife. I was a doula. And that's just because every country classifies us as something different. So in them calling me a midwife when I was working in Stuttgart, Germany, that's because they saw me more as like a lay midwife who would do a lot of the body work, and I would do the wellness of a mother, everything that's not medical. So when I meet families or mothers who aren't necessarily through self-care, it's through a collective or organization, or they could be through a caseworker or through a church member. So I wouldn't say it's necessarily self. It's really like Dr. Andrea said, it's about the more information that they're getting, then they then are able to attribute the information that trickles down to, okay, if I'm going to see a dietitian or if I'm going to see someone who's a clinician, then that person who's a provider can say, have you considered a doula? This person's on staff and this person come to your home. Because many of the doulas that work with women, they go to their home so that it eliminates their numerous trips that they're making to these health facilities, or it takes away the distractions or the inability to get the care. So it's still very much community-based, but it's also word of mouth. And even though it's all these different facets, it's still in a place where at the core, it's to really serve the woman, to really meet her need, so that however she gets to us, she's able to still say, okay, I may not have gone to you directly, but there was a reference point that brought that doula her way.
Okay. So one of the things that's kind of coming to my mind right now is that what you are both describing to me sounds like competent healthcare. I mean, culturally competent in that you're working with populations that are not, that aren't white, cis, American, Western, culture, that you're working with people who look different, have different lives and all that. But what you're describing is good healthcare. So how is it that what you are doing is different from, why are you different? Andrea, will you start there?
Yeah, sure. I feel that we're not necessarily different than the main healthcare system. I think people are really hungry for good healthcare, and the system that we currently have has perverse incentives to not provide good healthcare. Right? You get paid by every single thing you do, so people are really reluctant to get care. Our insurance system, women don't. I mean, Houston, Texas is one of the worst states in maternal mortality, largely because women, can't get health insurance, can't get Medicaid immediately, and no provider will touch them without the Medicaid. So a lot of women wait those 45, 60 days to get Medicaid before they get to see a doctor. And then, we're really behind on care. So people are really hungry for systems of care that will take care of them when they need to be taken care of, and not when they've jumped through all the hoops to access it. So I don't think we're different. I think we're just more caring for the patient. And I will say that doulas are incredibly powerful, and that they bring that space where physicians cannot touch, that space of trust, that space where half of our patients walk out of the exam room not knowing what the doctor said.
Mm-hmm.
And it's really critical for that translation, not necessarily from one language to the other, but from the translation from what the doctor told me to what do I actually need to do and what happened in the exam room. And that's, I think, that the critical space where doula and other community health workers have. And to us, so the way we operate, and I think we talked a little bit about this, Cecelia, is that the way we hire our medical providers, and you asked me if our providers are, speak many languages. So we have a big variety of languages, but that's not why I hire our physicians. Our physicians are hired because they feel comfortable providing care in a universal way, in terms of really caring for a very diverse population. And many people don't feel comfortable going and talking to a person who is Muslim. Many people don't want to talk to a person that is, Chinese. They don't have that in them. So you really need providers that are globality carers, that they like diversity, that they embrace it, that they are willing to listen and learn, and not necessarily providers that, and there's nothing wrong in one or the other. I don't, hold people, I don't judge people because they prefer one thing or the other. I think it's really tough. Medicine is a tough space, and doctors by nature, we're fixers. You come with me to a problem and I want to fix you. And I think that intersection of I'm going to fix you and not I'm going to listen to you is a tough place to be, and it's very frustrating. So if you can't understand your patient correctly, if you can't, a patient can't pay for their bills, if the patient can't get their medications, and you're going to see them in 3 months and they're going to be worse because of all the barriers they have and you cannot control, then then you end up in a very tough situation as a fixer. And so it's really taxing for a provider to go there. So, being able to choose providers that are willing to take that burden, that are willing to take that extra leap of faith in working with a doula, working with a system of care that will translate their intentions is I think is what makes us a unique provider, and a provider that is willing to go in that extra length to take care of this population that otherwise would really go out without care.
Velesha, do you have anything to add?
Yes, I agree with what Andrea is saying. I think for doulas, me speaking as a birth doula, in an activist role, I am very different. And I'm different because my job is to go and to navigate and dismantle the system that a woman might feel is not going to give her the birth that she's looking for. And I say that because that's very fact driven. For me as a doula, and many doulas who are activists, our job is to basically kind of disrupt the system so that the mortality rate, depending on where a mother is birthing, is low, specifically for women of color. I became a doula because women of color, 3 out of 4 women would die. And that's a really bad number. And I also became a doula because I wanted more women to understand that when they understand the system and someone can navigate it for them and speak on their own language, they have a better option of knowing what their choices are. When you know choices and you know there's different routes, you know what's best for you, and you know the medical side, you know the holistic side, and you can make the best decision for you and don't feel like you're being bullied. So I feel that as a doula, we disrupt the system to really educate these families that go in to ask the hard questions, have informed consent, know that until they get their answers that they're looking for, they should not make decisions unless they clearly understand it. And doulas, we really flesh it out to explain it to them. It doesn't take away what the medical facility or the provider is saying, but the reality sometimes is that the timing of the provider may not have the 15, 20 minutes. They might have 8 or 9 minutes. It's our job as an educator. My job as a doula is to say, this is what's happening. These are the options that are being brought to the table for you. What do you want to do? And then what they're going to do, then I support them in that and making sure they're getting the best outcome, the best answers, and knowing on the other side what the pros, what the cons are, what's going to happen to them, what's going to happen to their baby, and knowing that they made the decision. So they feel much more empowered instead of making a decision from like a gloomy place. And they're just kind of saying, well, what if, should I? They're concrete and they can stand firm on their decision. I can support them along the way.
Thank you very much. I think that's really important. And one of the things that's coming up for me as I'm listening to this is that cultural competency also requires understanding of the issues within the community that you're working with and their attitudes towards the providers, right? So you brought up, Velesha, the working with women of color. And that's what my thesis was based on, right? And one of the things that I heard was a great deal of resentment and fear of medicine because of previous history with the medical providers and dealing with implicit bias. And Andrea, with your populations, you're dealing with implicit bias issues as well, but they don't have the same roots as perhaps an African-American population would be. You might have issues with refugees that are dealing with racial bias or racial bias that's happening within their own countries. And they're dealing with trauma from that. So you have a variety of different traumas that are happening because of the cultural situation of the populations that you're dealing with. Does that make sense, or am I off base with that?
I definitely, people come with, we have our own biases, and then the patient brings their own, experiences to the table as well. In a sense, for us, I think it may be easier to work with our refugee patients than it is working with the established African-American communities, because these communities are coming to do a fresh start, right? So you're already coming with a mentality, you're already a survivor by the fact that you're here. somehow you already have some level of resilience. And I've seen in some of our patients, especially some of the Kurdish patients that we've had and the Rohingyas, the level of traumas they've gone through in the refugee camps and escaping out of their countries, that is like, I don't know how, if I could have survived something like that. Just absolutely brutal, you know, seeing your family raped or murdered. And those are absolutely incredible traumas that patients come through, but they're come here and their level of resiliency in being able to move on and heal and being compliant with care and respectful of their care is just amazing. And I think that they're very vulnerable in that point. And I think in a way they're very lucky to find us because we surround them with a lot of support and we are a trusted provider of care. But in other systems, it would be, maybe they would take advantage of them. You know, maybe you can break that balance really easily. So we still are part of the trauma. I don't know if you understand, but
We do.
we talk about past trauma, past biases. We're actively creating that trauma, and we're actively part of creating barriers to our own people, right? So it's not just all on the past, it's also it's actively present on how we stigmatize people. For example, you know, people who came from Mexico and got stuck in the borders, and families who were separated. That's active trauma that we are current authors of. So we are creating that current mistrust in the community. It's not necessarily part of the past. So I think it's really powerful that we look at ourselves in the mirror and say, how can I actually, you know, embrace this active movement and stop the trauma today, stop the you know, cut that future that's coming of mistrust for this group of people that we know are already very frail to the system. So it's really important that we think about how we treat, because that's going to have a long-term impact, not only on them, but their future generations and how they perceive care providers and the system in general. Is going to come and hunt them for generations.
Yep, absolutely. And again, that will impact the healthcare and the health of the future generations as well. And that's part of what you're talking about, Velesha, right? When you're talking about African-American mothers, it's not just their trauma, it's the traumas that happened before them as well. Did you want to add anything, Velesha?
I was going to say, I completely agree with that. One thing that I do also as a doula that I would like everyone to know is when I'm working actively with my families, there's a really great, one of the organizations that I use a lot of their work and their articles to really submit the idea of not just telling a family what to do or telling a mother what to do, but giving them a guide. And I want to just share my screen quickly for everyone to see. This is generally what it looks like. Let me know if you can see. So if you can see, this is from the National Association to Advance Black Birth. And this is important because when I'm working with clients, even if they're not from the Black or Brown community, I want all women to know their rights. And I want them to know how to ask the questions. And what I found, not just in the capstone when I was a Goucher and using this in a lot of my research, just making this into like a pamphlet and handing it to my families to take with them into the room, to ask the questions for cultural competency. I've realized in it being a way that they're able to communicate, it gives them a clear guide within the 9-10 minutes that they're speaking to a provider to say, hey, how do I feel seen? How do I feel heard? Even in just saying whether or not they feel that they're being asked the right questions about their body. Do they feel that they're being informed? Do they feel that they're getting affordable care? Are they supported? Things like this that sound very simple. Many women I work with can't really sit and say, I've felt all these things. And it doesn't mean it's bad. It just means that they don't have a blueprint or a guide. And I'm a really huge person about having a guide, being someone proactive. And when I give this to them, versus their first time they might go in to see a provider, And the second time, they feel more prepared. They know how to ask the questions. And they feel not just that the questions are there to be asked, but they feel supported. And many times they might say, okay, V, which is what a lot of my clients call me, just having this as a guide, they're not kind of like just throwing random questions. They're very focused to then say, okay, is this provider going to give me what I need? Are they providing cultural competency? So the great example I'll give is this. If I work with a family, let's say, that has strong traditions and they do not believe in naming their child until they go through a naming ceremony, and they happen to go to a hospital where they have to be able to have a name picked out with the registrar, with the birth certificate right away. When we have this conversation, we converse, the conversation is, this may not be the best hospital for you to select. Because this is a place that has certain guidelines, you want to make sure that your culture is being respected. Maybe selecting another hospital, that's an example. Or maybe just the food that they're bringing in, like Andrea was saying, and helping the mothers to be able to recover and postpartum is huge in the competency of a culture and a mother, making sure that she's not just being heard and validated, but the food that she wants to nurture her body after she's had a birth is being brought into the home. I mean, not in the home, brought into the room, and that the providers and the nursing staff and the doula can support her completely to say it's completely okay to have it. You don't have to stick to just this because we know this is the nutrition, and she's gotten the green light to say this is the best way to care for her and make sure that we are encompassing her culture from a place of understanding and a place of knowing that she's making the decisions for what she wants for her wellness and her health.
Bravo. And this is a fabulous. Is this something that you found online? Or
no, so as a birth worker, I'm actually a member. A lot of birth workers, whether they're women of color or not, as long as you serve the community through this organization, the National Association to Advance Black Birth, this is given to most birth workers. So this is publicly online, but a lot of women who, if you're not in the birth work community, you may not know it exists. So for me, this is me being able to really push out this Bill of Rights map to all my clients, and it helps them tremendously. I've also given it to a lot of organizations I partner with. I've given it to a lot of birth collectives. A lot of the summits or the conferences, we use this as pretty much our guide to give to all our clients to say, give this to them, let this be their guide to empower them to then start the conversation with their provider. And it has helped, and it's great.
That's awesome. And I see at the bottom of the first page that the website is
Yes.
the NAB, THENAABB.org, right?
Underscore NAABB.
BB.
So
Okay.
the National Association to Advance Black Birth.
All right. Fabulous. Okay. Well, I could go on talking to you guys for, several more hours, but I know, Velesha, you've got a hard stop at 7:35. We've got some wonderful people participating in our community, participating in the audience here. I want to throw it open. What do you want to ask each other? Do we have any questions in the audience? If you'd like to throw a question into the chat, I'm very grateful all of you are here. What do we have as first questions?
I've got one.
Yeah, go ahead.
Okay. Hi, sorry, Jennifer. Thank you all so much. This is wonderful, and so insightful and timely. So my question is to both of you, but Andrea, you brought it up. But I'm interested in, so you use, and I teach in public health, so use the word upstream healthcare, and so I'm interested in some examples maybe of how you see the intersection between what you're doing and that upstream healthcare. You talked a little bit about going to patients in their home and things like that, so I'd love to just hear more of that.
Yeah, and we have several upstream projects that we have created over the years. One of them is called Bite of Hope, and you can also go to their website. I'll type it in. It's the biteofhope.org, and it is a food insecurity project where we actually have a chef on our staff, and the chef works, does several things. One, of course, provides nutritional classes to our diabetics, our pregnant moms, our seniors. We also teach at the middle school kids. We have 600 kids that we teach classes, some in person, some online. We provide all the food to the families for the class, and we encourage the child cooking with the family online live, and it's a lot of fun. We have a culinary institute. We just graduated our first cohort of participants. Some of them and it was an incredible project where we've had some of our diabetic, some of the participants were diabetic, and one of them said, I've been, my family has suffered from diabetes for generations, and we've never, been able to find a way of preserving our foods and our flavors and knowing exactly how to cook in a healthier way and be motivated. And this is a full certification culinary school, 8 weeks, 3 days a week plus Saturday, so 4 days a week, 8 hours a day, and they end up with a certification. So you're not only giving them education and healthy eating, but you're actually giving them a upstream, a economical venue to have a new job. And one of the other women said, I've always loved to cook. I clean houses. I've been cleaning houses for the last 20 years, and I've always wanted to have a career in the culinary arts, but it was absolutely unaffordable to have a cooking have cooking lessons, and let alone cooking lessons that would teach me how to improve my health. So the program, it really has been incredibly successful in terms of bringing a chef into the clinic that comes from a total different position than a nutritionist, right? A nutritionist always comes to the clinic and points your finger and says, you eat too much carbs, you eat too much sugar, your plate is too big. Let me show you how a real plate looks. And the chef comes from a completely different point of view and says, okay, let's cook. Let's do something fun. And let me teach you how to cut the onions, and, let me teach you how to, sweeten your cake with banana instead of, or let me teach you how to use some vinegar to enhance the flavor. He comes from a completely different point of view than a nutritionist. And because there's no judgment in that, everybody wants to see the chef. The chef is like an urban myth, And so I think that's one example of one of our upstream projects. We also have a maternal health upstream project that was funded by I think the Kellogg Foundation, where we looked at part of the BUILD program. Not sure if you're familiar with that, where we worked with community workers, not quite doulas, but community workers, to go into the communities and listen to what are the priorities of young women. What are they, thinking when they think about family planning, and empowering them to ask the right questions. And then on the flip side, working with providers and helping them understand their community, because so many times providers, especially at hospitals, you go to the hospital, you get in your car and you go back home, and you get in your car and you go to the house. You have no idea who you're serving. You have no idea, what the neighborhood looks like. You don't know what it takes for a patient to walk to the practice. You don't know. And the hospitals is like an island inside a community. There's absolutely no interaction between both of them. So the project was really designed to bridge that understanding from the providers. And you talk about cultural competency training for providers, or bias, racial bias on them. But definitely, I think that doing a PowerPoint presentation and trying to understand that we all have biases, but it's a very different story to be outside those walls and walking in the potholes, walking in the sun, being splashed by having to get off the sidewalk because there's no sidewalk. Really understanding that environment from the physical point of view and not just from a PowerPoint with pictures is a very different experience. So part of that is, bringing the hospital out of those walls, making it, walk out through the community and meet the reality of the patients, and then bringing them back. So you don't need to necessarily preach to them on, you're so biased and you don't understand the community, but actually show them what reality is. We all come, I think that, healthcare people, they come with the right attitude, it just gets changed over time through so many different pressures of the system. And we just need to get people out the doors and into the sun.
Thank you.
Yeah, one of the things that I heard about, one of the first American Folklore Society conferences that I went to, someone introduced me to, and I wish I still had his business card. It was an artist that was affiliated with a FQHC in New York, and they had hired him to actually put together an art gallery for the community that was part of the hospital, that required, in order for the doctors to come in and get to work, they had to go through the art gallery, and that was the community's space. So they didn't walk in directly into their own space. They had to go through the community's space first before they could go to their job. And that actually, they found that really impacted the attitudes of providers and the staff when they served the community on a daily basis, which, that's another way of doing it. So what other questions have we got? We've got 3 minutes before we lose Velesha, who has a great question for Velesha. I heard her mother's here. This is your opportunity, Mom. You can grill your kid here if you would like to. You must be very proud of her. Okay, she's staying incognito. What do we have? What would you like to ask of each other? Velesha and Andrea.
I'm sorry, did somebody call me? I stepped away.
Yeah, there you are. I was giving you the opportunity to poke and prod at your daughter, or celebrate her, or ask her a question, or grill her. So
yeah, so I wanted to ask Velesha, how is it you came by this passion to be a doula, Velesha? But maybe you can tell the audience.
Okay, sure. So I came about this passion. I was like, yes, can everyone hear me? So I came
Yes.
into being a doula. Well, I had already been working in postpartum care for a couple of years before being a birth doula. Once I had my daughter, who was 6, I had an amazing birth team, and I had an amazing birth team work with me because I happen to be blessed to have family who lives in different countries, and I was not being heard from my OBGYN. And I felt that every time I was going and she wasn't hearing me, I was getting to ask the same questions. And one of my aunts said to me, why don't you just switch to a midwife? Like, she said it very matter of fact, like, see a midwife. And I was like, can I do that? And she said yes. And I happened to have an amazing birth educator that helped me along the way. I researched it. And in me doing that, I was able to have an awesome midwife team that was none of the women were women of color. They all were white women. But what I remember is that when I told them I was kind of interested in learning more about my body, they taught me about my body, and they taught me that the importance of cultural competency is going to take me further if I become a doula, and that more women need to know that they need care, and they need to be doulas, not from trauma. And that's what led me to being a doula. And as I started researching, taking the classes, going through certification, I then was able to realize that my love for women, my passion for community work and serving my community, because I'm first generation American, both my parents are immigrants from Jamaica and St. Vincent, it's very natural and innate in my brother, my sister, and I to be community workers. Like, that's just what we've seen our whole life. And my great grandmother was a midwife in Jamaica, and my great aunt, her sister, was also a midwife. So in this, I realized I was gonna end up becoming a doula. Whether I realized it or not, is just that my path drove me into this area, and the work I do is a gift and it's a passion because it's very natural to me, but it also is an area where I feel that I'm able to be an advocate. And that's how I became a doula for the women I work with in the community. And that's how I was able to find my passion. And going to Goucher is what really helped to undergird me and really hone and develop and cultivate my skills as an anthropologist, to see that the work I do can be very multifaceted in different areas, and it can bring all of my years of experience in undergrad as a journalism and into folklorist and into anthropology together and working for the community.
Yeah, and may I add to that, my grandmother, she birthed all of us except for one. 7 children at home, twins included. And I was like, oh my gosh, how did Velesha get this? You know how it travels down the line. How did she have this passion? Even yesterday, my elder sister who lives in Canada, she says, Velesha got this honestly. She just loved what she's doing, you know, the doula. And then she comes home and she tells me these stories. I said, Velesha, that was your grandmother. So I'm very proud of Velesha that the legacy continues. And she has this passion for women and for babies, you know. And so I wish my grandmother, if she could look into time and see that all the work that she did in the community, delivering all these babies, here it is, her great-granddaughter is doing the same thing. So I told her she's gifted, and I congratulate her on all that she does. And when she tells me that she is sought after, I said, oh my gosh, she's really sought after in Maryland, in Germany, and other places. So I expect greater things to come from Velesha, you know, because she has the passion. She does not do this only for money, although, you know, she has offered some what they say, freebies, that's for lack of better words, because, you know, she likes to help others. That's who she is. And she has a heart and a passion for this, which is awesome. Thank you very much for the time.
You're
Thank you,
very
Mom.
welcome. I'm so glad. Thank you. Okay, I see Amy's window on. I guess I have to stop talking now.
Well, I just want to be mindful of people's time. I know that Velesha needs to leave and people are starting to fall off. So I just want to say thank you to all three of you. Cecelia, thank you for the idea. I think this was Cecilia's idea to try to pull together this conversation. And then Velesha came to our residency in July and spoke so passionately that we put the two of them together. And then Cecelia said, oh, but I have this doctor, Andrea, that really needs to be part of this conversation. So this has just been wonderful. The three of you are natural, passionate advocates, and I love the work that you're doing. The clinic where you work, Andrea, just sounds amazing. You sound like an amazing leader there. And Cecelia, thanks for all the great questions and moderating this. And Velesha, thank you for joining us and sharing your passion and bringing some of your family to the conversation as well. It's been really great. So, as I said, we will be this recording will get posted up to our YouTube channel, so you'll get to take a look at it and see it again. And Zarita, thanks for coming. It was great to see you here. And Taylor has posted some names and some contact information if you're at all interested in graduate programs at Goucher or learning more about that. And just as a last reminder, October 24th, we will have an information session about the program. So thank you all so very much. This has just been wonderful. Oh yes, and Andrea, both Marty and Andrea have posted